Our first thyroid neoplasia will be our adenoma. Adenoma means benign tumor of glandular origin. Okay. The most common type is going to be our follicular adenoma. Clinically, the patient will present with this painless solitary lesion and may appear as a cold nodule on thyroid scan. So what we're saying is, we talk about thyroid scans, we're looking to see if the lesion will uptake iodine. If it doesn't, it's considered a cold nodule. If it does, it's considered a warm or a hot nodule. Now, adenomas can be cold or warm. More likely they may be cold, but understand they can be warm. Okay, that's important when we compare it to our carcinomas, because carcinomas are always going to be cold nodules. Okay, so they're not going to be associated with increased function of the thyroid gland. So in the exam, if a patient presents with a cold nodule, you first want to think that it could be carcinoma, but understand it could be an adenoma as well. So the adenoma, as I said, can be functional, so it may be associated with hyperthyroidism, so-called toxic adenoma. In that case, you'll probably see that lesion be a warm or hot nodule. Now, as far as our malignant neoplasms of the thyroid gland, the most common one is going to be our papillary carcinoma, typically seen in females around peak ages between 20 and 50, and typically associated with radiation exposure. Believe it or not, years ago, they actually used radiation to treat acne. So these women would get radiation to the face and neck because of acne, and then later on they got papillary carcinoma. And of course, the survivors of the atom bomb in Nagasaki and Hiroshima, these females also got papillary carcinoma as well. Microscopically, the key is you're going to have these so-called papillary or finger-like projections of tissue, and they're going to be lined by cells. They're going to have the clear or vesicular nuclei, so you're not going to see the typical features of the carcinoma. Sometimes they'll describe these nuclei as so-called orphan eyes. You ever see the comic strip Orphan Annie? They drew her eyes as a big circle with a little dot in it. So the little dot is a prominent nucleoli, so that's classic. You also get these so-called nuclear grooves and intranuclear cytoplasmic inclusions. Here's our biopsy of the papillary carcinoma. So you can see the little papillary or finger-like structures here. Now look at the nuclei, nice and round, but they're clear. Okay. So again, the so-called orphan eyes, okay, nice and round and clear, or vesicular is the other term you'll see. Okay. However, don't forget, you get the psammoma body, small round dystrophic calcification. They can also be seen with your meningioma and your papillary serous adenocarcinoma of the ovary. Now, this tumor typically spreads via lymphatics. Okay? Treatment with resection typically is curative in most cases. Radiotherapy with iodine-131 is also effective for the metastatic lesions. Now, because the tumor spreads slowly via the lymphatics, the prognosis is excellent, and patients have a 20-year survival rate of about 90%, as opposed to our follicular carcinoma. Here accounts for about 15% of your thyroid tumors. You can be seen in females, going to be older. Now, this tumor will spread via the blood. Because of that, we'll have a worse prognosis than your papillary carcinoma. Also, the follicles look just like the follicles of your follicular adenoma. So the key is to make our diagnosis of follicular carcinoma, you must see vascular or capsular invasion. Okay, so you got to see the follicles invading a blood vessel or the capsule of a lesion to make a diagnosis of follicular carcinoma. Moving on to our medullary carcinoma. Now first, the term medullary means kind of soft or in the middle. So this tumor won't be hard like your garden variety carcinoma. You see here accounts for a small percentage of your malignant thyroid tumors. It arises from the perifollicular or C cells, which make calcitonin, which suppress calcium levels. Calcitonin toned down, okay? Microscopically, this tumor will have a so-called amyloid stroma. So again, Congo red positive, apple-green birefringence, under polarized light, that kind of thing for your amyloid, okay? This tumor may be associated with MEN2 and MEN3, and these patients typically have a poor prognosis. Here's a biopsy of our follicular carcinoma, and notice how the follicles look like normal follicles that you typically see in the thyroid, okay? However, here, You can see the follicles in this round structure, which is a blood vessel, again, showing you the vascular invasion. Okay, so therefore, look for the follicles either in a blood vessel or the capsule of the lesion to call it follicular carcinoma. Moving on to our anaplastic carcinoma. So again, the term anaplasia means that the cells are undifferentiated, but by definition, all anaplastic tumors are malignant. Okay, these tumors are most commonly seen in females, typically going to be older, greater than the age of 60. Okay, now the tumor can be large and bulky. Again, can compress the trachea and the esophagus. Okay, you can have early widespread metastasis. So as you can see, the prognosis is very poor. And when we do a biopsy, we're going to see these very atypical, undifferentiated, and pleomorphic cells. Again, very aggressive and rapidly fatal.